good afternoon. I'm very pleased to welcome all of you to this special presentation today on aging and wellness, entitled Perspectives of a Wellness Researcher Prioritizing Emotional Well-Being and Resilience in the Care of Older People. I'm Tom Muser. I direct the UNE Center for Excellence in Aging and Health, and my center is one of a partnership that's bringing this presentation to you today. I want to acknowledge the Center for Excellence in Collaborative Education under the leadership of Shelley Cohen-Conrad and her very capable team for making this particular program today possible. We're streaming to multiple locations. We have medical students down on our Biddeford campus. We have community professionals dialing in from many different places, and we have a room full of students here on the Portland campus. You'll soon hear from Dr. Fullen about his perspectives, but I want to do a little bit more acknowledgement before we continue. And I don't know if I can still be heard clearly. We're getting some feedback in the room. This event is also made possible through a collaboration with the co-occurring Collaborative Serving Maine, or CCSME, who is providing continuing education credits and opportunities for participants. And it's made possible through funding by our own Training in Aging and Diversity program through our School of Social Work, which is funded through HRSA. And I would like to welcome Kelly Fox, the PI for that program, to come up and say a quick welcome.
So welcome, Dr. Fullen. I'm delighted that you're here with us and that you have so much to offer to our students and our community, so I'm grateful for that. So the Triad grant, which is a HRSA-funded grant for health and wellness education and training for our social work students, is a grant that is meant to offer an opportunity for students to learn more about working with older adults in a variety of clinical settings. So this is our final year of the grant, so those of you who are grant recipients, I'm so delighted to have you. And I think this is our 5th class, so glad you're all here and that you could join us, including the folks who are online.
Thanks, Kelly. I want to thank the CC team, Chris Hall and Michelle Cody, for their capable work in getting this arranged. I also want to thank our amazing technology gurus here at UNE, David Diego and Lee Cody, who are also making this possible. Our dean, Dr. Jen Morton, will do the introduction of Dr. Fullen. So, Dr. Morton.
Hello, everyone, and thank you for having me. I just heard a rumor that there's over 100 folks that are coming in remotely, and we have quite a few in the room here, so this is truly a very exciting time. UNE's become a niche in the care of older adults and understanding older adults, and part of that is through the Center for Excellence in Aging Health and grants like the Triad grant. So we are we're lucky to have such expertise here, and we're very lucky to get someone of Dr. Fullen's caliber to be able to come and train students, provide perspective, and just be part of this wonderful community that honors older adults. So in introducing Dr. Fullen, Dr. Fullen's topic fits nicely into UNE's emphasis on interprofessional practice. That is another area, a niche area for us, in addition to the care of older adults, is the way we care for older adults and everyone else in teams that function really well. Dr. Fullen is an associate professor of counselor education at Virginia Tech University in Blacksburg, Virginia. He is also an affiliate faculty for the University or Virginia Tech Center for Gerontology. He has worked with older adults since 2005, first in the affordable senior housing industry, and then as a licensed professional clinical counselor in various settings, including long-term care, adult day, and private practice settings. He received his PhD in counselor education and supervision from The Ohio State University, a Master of Divinity from Ashland Theological Seminary, a Master's in Clinical Counseling from Ashland Theological Seminary, and a BA in Psychology, Religion, and Political Science from Northwestern University. Dr. Fullen is one of the most active gerontologic scholars within the counseling profession, and his work has been funded by federal, private, nonprofit, and university-based grants. Welcome, Dr. Fullen. We're really looking forward to your time here in Portland.
Thank you so much. It's wonderful to be here, to spend time with all of you, both here in person and those of you tuning in online. So thank you so much for taking time out of your busy schedules to learn about these important topics. And so today I'll be talking about the intersection of three incredibly important topics, and those are aging, emotional well-being, and resilience. And each of these is particularly timely given the recent experience of the COVID-19 pandemic and the way in which it illuminated certain vulnerabilities that older people are facing right now and continue to face, as well as the resilient responses that followed. My interest in aging, emotional well-being, and resilience dates back to 2005. I had recently been hired by a large nonprofit organization that was owned and operated affordable senior housing. And within the first few weeks of the job, I was sent, along with a colleague, to New Orleans to respond to older adults who had been impacted by Hurricane Katrina. And this was a profound initial encounter with resilient aging, and really shaped some of my thinking around how do we help meet people, older adults in particular, in times of need, in times of great distress, and how do we help locate and help them locate areas of strength and resilience along the way. Later, my interests in resilient aging and whole person well-being grew as I worked as a licensed professional counselor in long-term care settings in north central Ohio. And that's where I first met Geraldine. Geraldine, an 80-something-year-old resident who had recently moved in after chronic bouts with COPD and frequent trips to the emergency room. Geraldine was referred to me by staff social workers after they had noticed that Geraldine appeared to be depressed. And I was told that Geraldine had been dealing with some significant losses. I'm going to share some of that with you. But it wasn't clear until I first met and interviewed Geraldine just how much she was hurting. So from that standpoint, even that day, trying to use a whole person lens for assessing and understanding Geraldine, I learned that she was facing a litany of issues. Biologically, Geraldine was hampered by COPD, emphysema, and needing to be hooked up to oxygen at nearly all times. She was also receiving a long list of medications, and she confided in me a concern about getting hooked on some of the painkillers that she was receiving. Psychologically, Geraldine exhibited signs and symptoms of anxiety and depression, and she was struggling with family and grief issues as well. She had a lot of questions and concerns about moving into this long-term care setting. She wanted that to be temporary. She wanted to get back to what she believed to be home. And she had questions, how long am I going to have to be here? When can I move back in with my daughter? Socially, relationally, Geraldine revealed to me that she had lost 2 of 5 adult children to tragic deaths, including a son who had died of brain cancer in the past year. She also had another child who had overdosed about 10 years prior and had died. And the grief and loss associated with these deaths was something that Geraldine was working through and was very much aware of internally, and yet didn't have spaces to be able to really talk about that where she was. Of the 3 living children, 2 of them lived out of state, and 1 daughter lived locally, and that was the daughter and the home that Geraldine was hoping to return to. She shared with me through this conversation around her family allusions to a family system that was both very close but also fractured in important ways. We also talked about Geraldine's spiritual needs and some of the beliefs that she had that were helping serve as resources and strengths for her. She shared with me that she had dabbled in various forms of religion and spirituality. She currently identified herself primarily as a Christian and through her son's death, was reflecting quite a bit on her own views and values around faith and also how to move forward at this time of her life. Little did I know at that time that this first meeting with Geraldine would come to represent a working definition of resilience. Not because of anything particularly exceptional about her, but due to the simple fact that she was willing to persevere day by day in the face of many trials. And she taught me through that time, and I hope to convey to you, that resilience is something that all people possess once they and once we know where to look for it. And during our first meeting, Geraldine mentioned that she had always wanted to write a story about her life, but she figured that at her age it probably would never happen. And so at the end of this initial clinical interview, she looked at me with sort of a twinkle in her eye and joked, "Maybe you'll write that story about me someday." And so using Geraldine's story as a backdrop, I hope we can explore emotional well-being, resilience, just how commonplace this pursuit of resilience is for people like Geraldine whom we serve. And by better thinking about older adults and thinking about the ways that we can foster resilience and whole person wellness among them, I hope that you'll leave here today speaking the language of wellness and resilience to the people that you serve and in the places where you live and work as well. Now, before we dive in and spend more time talking about these topics, I'm going to ask you, particularly those of you tuned in, but also you here with your phone or your laptop, to tell me a little bit about how you think about wellness. So when you think about older adults and wellness, what attributes come to mind? And you can navigate to the link here on the left-hand side of the screen, and you will be asked to enter either a single word or a phrase to help contribute to a word cloud. And you'll see here that if you want to contribute a phrase that is 2 or more words, you have to put the underscore in between those words for it to come up. And so we're going to give you all a little bit of time to think about wellness in the context of older adulthood. What attributes come to mind? And I see some answers coming up in the chat, as well as on the screen here.
I love that the word purpose is coming up in the chat.
Yeah. All right, keep them coming. All right, we'll start to talk a little bit about this as it continues to take shape. But you can see there in the center this sort of tension between independence and support. That's a really fascinating thing to try to make sense of, as well as health, connection, community. We've got quality, we've got purpose, and then a whole host of other facets of wellness in older adulthood. So I hope that this is something that you'll think about some of the things popping up here in regard to how we help people navigate this pursuit of autonomy, as well as the need for maybe more supports and more helps along the way. All right. Well, let's move forward in our discussion of emotional well-being and resilience. So when we look at narratives around older adulthood, we sometimes see these somewhat contradictory messages. On the one hand, when we look at research on life satisfaction in older adulthood, on the whole, older adults actually rate as having the highest levels of life satisfaction. That may or may not come as a surprise to you, but older adults actually report higher levels of life satisfaction than young adults and middle-aged adults. Older adults, on the whole, are more likely to report a satisfying marriage, and they outperform younger individuals when it comes to remaining calm during times of stress. So right off the bat, we see a host of resources and strengths and potentialities that accompany older adulthood. And we know that subjective well-being in this population is particularly high when older people perceive that they have adequate social support, a sense of control and mastery, opportunities to derive meaning through paid or unpaid work, participation in chosen spiritual or religious practices, and a positive perception of their age, just to name a few different facets that are predictive of well-being in older adulthood. So I hope that what we're doing here is building out a narrative in which we can see that older adults have just as much potential, if not more potential, for high degrees of life satisfaction and emotional well-being as the rest of us. And yet we also, sort of as a separate, somewhat contradictory narrative, we understand that there is a growing need for access to mental health care. The pandemic has been particularly challenging for people in older adulthood. 1 in 4 Medicare beneficiaries reported anxiety or depression, compared to only 1 in 10 prior to the pandemic. We also see on the right-hand side over 100 million Americans living in areas of the country where mental health care providers are in short supply. And in spite of the fact that 2 out of 3 Medicare beneficiaries said, I would be open to working with a professional if I had access to a professional to work on mental health care, we also know that there are many barriers in place, and one of those barriers is cost. Older adults talk about not having the resources to be able to access these mental health services. When we look at mental health access that goes unmet, and when we look at some of the worst case scenarios where older adults are struggling with untreated depression or anxiety, we can also start to make linkages to things like suicide risk. Older adults globally have the highest rate of suicide, and in the United States, the suicide rate for older adults exceeds the national average as well as the average rate among younger people. Older white men complete suicide at a rate of about double the national average, and this rate doubles again when we look at older white men ages 85 and up. So we're trying to make sense of how is it on the one hand we have older adults who have this high potentiality for life satisfaction, but on the other hand we're seeing cases of elevated suicide risk, of elevations in depression and anxiety. And so we need to use some critical thinking to really understand what are some of the facets that allow for certain people to experience that flourishing in older adulthood while other people are really struggling in very difficult ways. One possible explanation that I might propose is on the left-hand side, you see that when we take mental health professions and look at specializations in older adulthood, people tend to be not particularly enthusiastic in terms of going into those specializations. Fewer than half of geriatric psychiatry fellowships go unfilled in a given year. Only 4% of psychologists say that they want to work with older people, about 9% of social workers. On the right-hand side, you see that maybe there's another explanation, a similar explanation, and yet one that is even more kind of macro-systemic. Current Medicare policy restricts which providers can work within the Medicare program. And the list of providers here, psychiatrists, psychologists, clinical social workers, and psychiatric nurses, that range of professionals leaves out about 35%, roughly, of the graduate mental health workforce. And we come to find out that this list of providers was last updated by Congress in 1989, 33 years ago. So in spite of there being efforts to make changes to that, to open Medicare up to the full range of providers, we can start to make sense of why, on one hand, older adults through the developmental process are on a trajectory to experience wellness and resilience. And yet when it comes to kind of case by case, people that need extra mental health supports, need more resources to accomplish emotional well-being, we see under-resourcing happening. I want to share with you just a very brief anecdote around this. This was from a qualitative study that we did with mental health providers who are currently working with a license not recognized by the Medicare program. One individual, we'll call him Brandon, was the director of the entire behavioral health unit of a rural health clinic. They would occasionally have older adult patients who were receiving dental care, medical care, and they have behavioral health services available on site to work with those individuals. But he described it this way. He said, I meet monthly with community private practice providers, and they're all booked up. There's just not enough licensed providers in town to see everybody. And I know that because only half of those people can accept Medicare, it has a particular impact on Medicare recipients. So there's this general shortage of licensed mental health providers. There's an extra barrier for Medicare recipients, just solely based on the fact that half of the providers in town can't see Medicare patients. Okay? And Brandon talked about having an LCSW on staff and how that unlocked many of these resources until that person relocated, and then they couldn't find another LCSW to replace them with. And so for several months, the behavioral health resources just stopped if you had Medicare, if you were an older adult looking for help. So I say this as one way to understand how we can simultaneously have older adults with this great potential, and yet we as providers, we as policymakers, oftentimes not living up to our side of the bargain. From here, I want to introduce a way of thinking about holistic wellness for older adults. I want us getting back on that track of thinking about how do we help older people achieve optimal well-being. And one thing that stuck out to me in my work with Geraldine, the individual I described at the beginning of the talk, one thing I noticed as I began working with her was that nearly every professional encounter she had with other staff members was characterized by two attributes. The first being that almost every encounter was focused on Geraldine's physical self, almost as if that was all there was. And don't get me wrong, Geraldine had a lot of physical ailments that she was trying to navigate. I mentioned the COPD, I mentioned emphysema, but it struck me that there were all of these services connected to Geraldine's physical self, while when she and I chatted, there was so much more. What she wanted to talk about, what was concerning to her. She wanted to talk about her adjustment to the long-term care setting. And yet every conversation that she was receiving was focused on simply her body. The second attribute of those conversations was that nearly every encounter was focused on the ways that her body was breaking down. There was very little conversation around strengths, resources, resilience. And so it became more and more clear to me as I got to know Geraldine that this was a woman who had a vastness to her, both in terms of the breadth of the things that she cared about, and this was a person who had a lot to offer. And yet those professional encounters seemed to only be able to focus on the way her body was failing her, almost as if there was nothing else to talk about. Okay? So through the course of that conversation with Geraldine, and through the course of then learning about what made her tick, I began to develop this 8 dimensions of wellness model that you see here. I'm going to quickly walk you through each of those dimensions. So the first dimension, which is on the next slide, focuses on relational wellness. And relational wellness is primarily focused on the need for meaningful relationships with friends, partners, family members, and other people. And to be relationally well is to have meaningful relationships that are perceived as supportive, that provide a sense of mattering to others, that give the older person an opportunity to extend support as well as receive support. So we're talking about reciprocity of relationships. And that contribute to this notion that sufficient relational resources are available as I navigate later life. Okay? And as we're walking through this, I invite you to think about yourselves. Think about whether you have some of the domains of wellness represented and what it might look like to continue to have these as you age. The next slide focuses on spiritual wellness, the human need for meaning and purpose, as well as preferred participation in both individual and communal spiritual and religious activities. And to be well in this regard is to engage in preferred religious coping practices as needed, and to participate in communities where social support can be found. And you'll see here an effort to try to make this an inclusive and yet an important dimension for older adults to pursue. The next slide, we see the next dimension of wellness, physical wellness. And again, this is the area where so much attention was already drawn to Geraldine's case. An incredibly important dimension, of course, and a dimension that I think we have an opportunity to reframe for people. So with physical wellness, we're assessing this through questions like, Geraldine, in what ways do you continue to take care of your body? And a person can be physically well while also dealing with disability, chronic illness, or chronic pain. And so we're pushing back against any sort of notions that if I have a disability, I can't be physically well. No, we're saying no to that. We're saying that a person can absolutely continue to experience physical well-being even while they're navigating disability, chronic illness, or chronic pain. And to be physically well in this regard is to pay attention to my participation in diet and exercise, to perceive that I'm caring for my physical well-being, things of that nature. On the next slide, we'll see vocational wellness. Hopefully some of these are a little bit more novel and get you thinking about additional needs that Geraldine and other older adults might have. Vocational wellness is related to the pursuit of life calling, regardless of whether that calling is associated with paid work. It comes from the Latin vocare, meaning to call or to be called. And to be well in this regard is to find one's calling for each chapter of older adulthood. And to identify that we're not fixed to assumptions about retirement and post-retirement, meaning that vocation is no longer a part of your life. Instead, we want to flip that and say that a person's experience with work during earlier phases of life were a part of a deeper identity, a deeper sense of calling to a particular profession, or calling to care for their family in certain ways. And through that, we want to continue to promote that sense of vocation beyond paid work, or by looking at things like volunteering or other ways that people continue to find vocational identity beyond that sort of artificial juncture of retirement. The next dimension is emotional wellness. Part of this talk is about emotional well-being. Emotional wellness is vital to all of the other dimensions of well-being for older adults. Studies have found that emotional wellness is positively associated with cognitive health or brain health, and increased life satisfaction, and positive perceptions of future happiness. So I'm looking out at my future, and I'm looking forward to what next year holds. I'm looking forward to what 5 years from now holds. There are studies that show a connection between positive perceptions of my future self and the development of fewer mobility limitations. And so to be emotionally well is to be able to maintain hope, to maintain resilience, despite the many challenges that a person might face. And we'll talk a little bit more about resilience here in a few minutes. The next dimension, cognitive wellness, includes some things that aren't unique to older adulthood, but have a certain level of importance as people are aging. So cognitive wellness refers to the need for control, self-efficacy, a sense that I'm continuing to invest in brain health and learning. There's a lot of anxiousness and concern around brain health as people age. And so part of cognitive wellness is being able to make that ongoing investment in that part of myself. And to be well is to acknowledge the link between perceived control over my circumstances and my own subjective well-being. And so think back to that word cloud with, support and independence. And this is a really important tension that we have to walk, and as we're helping older adults through the aging process, have to continue to give them a sense of control while at the same time identifying the supports that may be necessary. Resilience shows up in this domain as well. That's just how much I like talking about resilience, because seeing oneself as resilient can enhance a positive perception of aging. And so think about resilience as the belief that I am able to bounce back from things. And think about how taking that with you into the unknowns of the future, whether you're 30 years old or 80 years old, that sense that I can walk forward into my unknown future and I'm going to be able to handle stuff because I know how to be resilient. That goes a long way when it comes to positive perceptions of aging. All right, just a couple more dimensions and then we'll talk about resilience. Contextual wellness. All right, this is a big one that is getting consolidated into a pretty brief slide here, but we're talking about older adults' financial well-being. We're talking about the communities that older adults are inhabiting and how living environments shape our lives as we age. And we know that this is something, our context is shaping all of us regardless of where we're at in the lifespan. And yet within older adulthood, there are unique ways that living context, financial context, access to housing, access to insurance, things of that nature, those have a unique bearing, maybe a particularly acute bearing on how we experience the aging process. And so to be well in this regard is to believe that one has financial resources to meet basic needs and maintain at least some lifestyle preferences, as well as inhabiting an environmental context that is viewed as age-friendly. Whether that is my home, my community that I live in, whether that is the town, the city, the state, the country, we can expand this to look as macro-systemically as you want to, and yet we know that environmental context shows up and has a great influence over people's lives. All right, the eighth and final dimension in this framework is what I call developmental wellness. And this is, again, one that we're always grappling with, and yet it really pops during older adulthood. So this is defined as cultivating a healthy, realistic attitude about the process of growing older. The reality that I am growing older, and some of the societal cues that are reminders of that. We want to cultivate healthy, realistic attitudes in response to that. So we might ask Geraldine or other people, what does growing older mean to you? How are you handling that part of your sense of self? And to be well in this regard is to be, again, realistic about unique challenges that older adulthood may bring with it. Also, to be imaginative about new ways to conceptualize the self and the life that I want to live as I'm aging. And to be hopeful, to cultivate a sense of hope, a sense of looking ahead, looking forward to what comes next, in awareness that older adults are resilient and have many strengths. And this developmental wellness dimension really is intended to push back on societal ageism and attitudes and perceptions of aging that tend to conflate the number of years you've been on this earth with certain qualities, skills, attributes. And so developmental wellness is a way to make sure that we're helping our older adult clients and patients also push back on that so that they can cultivate a more healthy, realistic attitude about growing older. This framework, which you'll see on the next slide, kind of the full framework altogether, this was developed out of some of those early clinical observations with Geraldine and other patients and clients like her. And, but it was directly grounded in empirical research on older adults specifically, and research that focused on what are those attributes that are predictive of life satisfaction, longevity, quality of life. There are other wellness dimensions out there, but most of them were developed with younger populations in mind. And so this was really built in hopes of having a way of thinking about holistic wellness that was developed with older people kind of at the forefront. Now, I have talked enough about this model in various contexts to also know that it has shortcomings. There are things that are not represented or that need to be explicitly represented. Sexual wellness is one of those that, you know, as I look at it, there are different categories where maybe sexual wellness could be represented, but there's more work to be done. This is not meant to be the final word on older adulthood and wellness, but is really meant to be a starting point to guide assessment, to guide conversation, to guide research. One of my graduate students put this together in sort of a one-page handout and was giving this to mental health counseling clients that he was working with as a way to get the conversation going about, you know, here's the full range of things that we are able to talk about as we get to know each other and get to work together. You know, your treatment, the time that you spend working with me does not have to be focused solely on one of these areas, but we can talk about which of these areas are you struggling with, which of these areas is maybe a strength for you. And that gets us to this thinking around strengths and resilience and how we take something like that model and begin to flesh it out in recognition that older people might look at that and grab certain things that aren't going so well, and they might also grab certain things where they feel like they've got a lot going for them. Resilience, just to sort of get us all on the same page, resilience has to do with the capacity to recover quickly from difficulties. There's a sense of toughness connected to it. And when we think about resilience, oftentimes the sort of semantic range has to do with like rebuilding a structure. And so there's this talk of, you know, an object being able to spring back into shape, having a sense of elasticity. So these are helpful, you know, to a degree. This notion of bouncing back is something that we commonly see in discussions of resilience. I want to push our resilience talk a little bit further. So on the next slide, what you'll see is that there's more to the story than just that. For a long time in the study of human resilience or psychological resilience, there was an assumption that certain people have it and certain people don't have it. And so it makes it easy to measure, right? You know, if it's a resilience trait, then I could give each of you a resilience inventory and maybe find out who the resilient ones are. Maybe you already know among yourselves, and who the less resilient ones are, okay? Not particularly aligned with sort of the philosophical spirit of what we're trying to do here. So more recently, there's been an awareness that, well, perhaps resilience isn't this kind of fixed quality that only some have. Perhaps it's something that is more dynamic, something that can be learned, a muscle that all of us possess, and yet we possess it with different degrees of strength attached to it, but something that we can work at. The other observation that researchers on resilience have made is that it's not just an individual trait that I sort of keep to myself. It shows up in community and in relationship. And so when we're thinking about resilience in the context of today's topic, we have to be aware that it shows up in at least three different kind of capacities. One, this notion of individual self-concept. You know, I am a resilient person. Number 2, that there's a relational level. I can rely on you in times of adversity, and therefore that makes us together resilient. And the third level is sort of a community level, that there are resources within our faith tradition, culture, community, historical tradition that make us collectively resilient. So these are all kind of horizons that we can draw from. And when we're thinking about someone like Geraldine, someone like ourselves, someone like other people we might be working with, we can start to do some assessment for resilience at all of these different levels. Okay? Other slides here on resilience just to kind of get us thinking. This is a chart that shows the typical trajectory of resilience for a building. This comes out of like architecture research. And so you see on the left-hand side, there's some initial degree of resilience that the person or that the edifice has. There's a disaster event that comes next. And then there are these phases of response, early recovery, recovery and reconstruction, and then a place where we're building back better. Have you ever heard that tagline, build back better? Okay. That wasn't made up. That comes out of this sort of way of thinking about resilience, reformative recovery, and a more resilient future. So a couple of things that are really interesting about this. One is that those phases imply that at some point you have to get back to whatever that initial level was before the crisis event or the disaster event happened. And on one hand, yeah, I get that. That's sort of baked into how we think about resilience, that you're bouncing back to some pre-existing state. And yet when we look at situations like New Orleans and Hurricane Katrina, Puerto Rico and all of the natural disasters that it has faced recently, sometimes with communities and as well with people, it's not good enough to just assume that you have to bounce back to some pre-existing state, because when we go through trauma, whether it's as a community or as a person, trying to become what we were before that is off the table. That's not really what the goal is. The goal evolves. And so on the next slide, what you see is that when we apply this to the notion of resilient aging and to our work with people like Geraldine, I don't necessarily want to pigeonhole resilience as if it's some return to a previous state of her development or a phase of life. And so instead of thinking of bouncing back as having to exceed that initial horizontal dotted line, I want to think of it as bouncing forward into whatever tomorrow might hold. And for Geraldine, that's going to look different than what her life looked like before she and I got to know each other. And even for communities, for places where we're talking about resilience, I think it's important for us to be advocates for some flexibility and dynamism in terms of thinking about what comes next. It's not just a return to what was before. All right. Got a couple more things to share here, and then we're going to do some case study work with some special accoutrement in the back for you in person here. I don't want to make the online audience too jealous. One thing I want to point out is that resilience can be kind of overlaid on that 8 dimensions of wellness model, and you can think about resilience showing up in kind of different parts of the person. So there might be a degree of physical resilience, and how do we think about that, assess that, support that? There might be emotional resilience that we can assess, support, move forward. Relational resilience. So just another way to kind of play with these ideas is to think about that sort of wellness wheel in 3 dimensions and think about the way that resilience then becomes a part of each of those. All right. Go to the next slide. A couple of other things in terms of clinical interviewing or kind of raising this topic of resilience. We want to help elicit discussion around resilience for people who may not have really thought of themselves in that way. And after our breakout groups, I'm going to tell you about one particular application of this, but one thing that we found in working with older adults is that not every older adult we worked with had resilience as part of their vocabulary, as part of their self-concept. And so we want to be able to do a little bit of operationalizing what that even is, and then asking people to tell us, in what ways have you demonstrated the ability to bounce forward? In what ways have you demonstrated the ability to be kind of gritty and tough and to bounce back after life throws something at you? We can also ask questions like, what can we do to help you grow in resilience? And so underlying that question is this idea that it's not fixed. So if you've never really thought of yourself that way, that's okay. We can start to build that in you. We can start to build that as part of your self-concept. A third way of getting at this is, how can I help you be resilient? And so that kind of embraces whatever professional role you might have with that person, and allows you then to help support sort of that relational resilience sense of the word. And then that fourth one is probably my favorite. It was shared with me by a graduate instructor, was just, how have you survived? And built within those four simple words is the assumption that life has been hard. Life has been traumatic. And yet you're here talking to me. That tells me something about you and your ability to survive. So how have you done it? What's your secret? Now think about Geraldine, and think about, Geraldine was an 83-year-old woman who, if you looked at her, there's not a whole lot particularly special that jumps off the page. And yet, I couldn't be more clear after having talked to her that she had survived a great deal because of her resilience. So being able to bring these questions into the conversation and to be able to ask things like, how have you survived, allows resilience to sort of manifest. Not only ways that they have survived, but then ways that they will survive in the future. All right, let's see if we have maybe one more. Okay, we're ready to do our breakout session. So for all of you here in person, as well as those of you online, we've carved out a little bit of time for you to think about Geraldine's case now that you have this 8 dimensions of wellness kind of in front of you, and now that you've thought about resilience in this new way. And so here is the kind of the hypothetical situation that I want you to consider. You've been invited to serve on an interprofessional or interdisciplinary treatment team that's providing care to Geraldine, 83 years old, living in this long-term care setting. That team consists of some combination of allied health professionals, peer support members, lay interventionists who volunteer with the local AAA. Whatever your professional or student role is, that's what you can take on. You can think about it through the lens of the profession that you are or are training to become. Your the Zoom or in-person small group may consist of members from all of these professions kind of mixed together, or it may be largely one or the other. And that's okay. These treatment teams can look any number of ways. But think about this through the lens of, how can we, using the things that we know about our discipline, refracted through these 8 dimensions of wellness, how can we help Geraldine? On the next slide, there's a little bit more in terms of kind of some conversation points. All right, so I'm just going to read this to you, and then we'll go ahead and get started. Geraldine, 83 years old, continues to manage COPD symptoms such as shortness of breath and a persistent cough while residing in a long-term care setting. But recently, she has also been complaining of low energy, feeling irritable, and experiencing tension in her relationship with her daughter. Geraldine describes feeling like a burden on people in her life, stating, "I just want to feel like myself again, and I wish I had more to look forward to each day." So in your breakout groups, please introduce yourself briefly, as well as your profession, and kind of how your profession might fit onto Geraldine's treatment team. And then based on what you've heard throughout our time together today, how would you use one or more of those 8 dimensions of wellness to develop a care plan for Geraldine? And how might you incorporate resilience at the individual, relationship, and community levels to help her achieve her goals? So that is your task. We'll give you some time to do that, and then we'll have a chance to kind of process your responses in a little bit. All right. Can they be, should they be dismissed for?
So folks, you can go get
Minutes to hear from our in-person and our online breakout groups. And so just to kind of get the ball rolling once again, could you provide a little bit of feedback about how you conceptualized using one or more of those 8 dimensions of wellness to develop a care plan for Geraldine, how you incorporated resilience, things like that to help her achieve her goals? So, and I believe we have some facilitators who are going to help with some of the online contributions. And maybe I could get us started with somebody here in person. Anything in between chewing? Anything you might want to share about your findings? Yeah.
I'm Audrey. I'm a social worker.
Audrey, nice to-
master's in the master's program
Yeah.
for social work. And I was thinking we would focus more on emotional, but we
Okay.
were also working in one of our other classes on solution-focused brief therapy,
Yeah.
which I thought a lot of the resilience questions aligned really well with.
Yeah.
And I just thought in general, kind of talking to her, I had a lot of questions, like,
course.
what is it about the facility that you don't like? Or
course.
do they have enough clubs and events to put on that you're entertained? Do you
Yeah.
have any like relationships within? So I just had a lot of questions.
Of course.
That I guess I would start with.
Yeah. Yeah, so you'd want to ask Geraldine questions to kind of get more into the weeds on like what she does or doesn't maybe prefer about that, just find more information. And then you were seeing connections between emotional wellness, resilience, and solution-focused brief therapy. Like that, that's a really strong connection. Thank you. Anyone else from in person here and then hear from our online groups?
I'm Tom. I'm also
Hi,
an
Tom.
MSW student. A couple things that we really keyed in on our conversation was how she said, you know, maybe you can write a story about me. And the idea of like, well, maybe you and I could write it together.
Yeah.
And we also sort of keyed in on how she said a little bit like a burden. And so you could engage some of the elements of like vocational and I guess cognitive
Yeah.
wellness. And go through the process of like redefining what her sense of purpose can look like and sort of, you know, doing some of that writing both in a, you know, maybe in a past focused sense, but also in a future focused way. Like,
Yeah.
let's write the next chapter
Yeah.
of your life. We may not be able to, you may not be able to meet that sense of purpose that you did, you know, at X point in your life. But we can redefine what it means to have a purpose. We can find something that helps you feel a little bit like more of a reciprocal relationship with your world.
Love that. Yeah. Yeah, thank you. A lot of amazing things. And I like how you tuned in to something that she said as sort of a throwaway comment. Like maybe you can write that book someday. But you heard that and you connected it back to the model and thought, well, we can actually do that. Wouldn't that be nice? And we can use that as sort of her language, then helping inform the next steps of her treatment, and thinking about how that ties into purpose and meaning. Love that. Love that. All right. Anything from our online audiences mediated through our facilitators?
So there's a lot of attention to her emotional wellness
Yeah.
and how that can be supported, some concerns about depression and assessing for that. But there's a very interesting comment from Michelle Dupre who says, make sure that a DEI interprofessional team to obtain a full picture of her assessment. So
Yeah.
I think her point is, you know, there are multiple areas to focus on, but let's get a full picture of Geraldine and how she's doing with some emphasis on diversity, equity, and inclusion.
Absolutely. Yeah, love that. Love that. And in some ways, I think what we're talking about today parallels the promise of interprofessional and interdisciplinary work, you know, that we can actually represent more of the whole picture when we have those different professionals working together and collaborating. It sort of allows us to tell a more accurate picture of what's going on with Geraldine. Yeah, so thank you for that.
And I'll just do one more before Tom grabs it. There's also some comments about nutrition
Okay.
and how, you know, she's taking care of herself from that perspective, and also her hobbies and talents and
Yeah.
things that can be capitalized on.
Love that. Yeah. Yeah, so there's a lot of opportunity. And again, I want to thank you all for engaging in a case study when you have like this little slice of information about her case. You all are doing a great job of acknowledging that, you know, there's more that we would need to understand from Geraldine before we can really draw some conclusions about how to help her. But yeah, things like nutrition, things like looking at what she has done in the past or is currently doing in terms of hobbies and leisure, things of that nature, and incorporating that into her treatment as well.
A comment I'll make from one of the posts was this notion of understanding her readiness to cope with some of these issues and to make change in support of her own wellness. To what degree? And I think that concept of readiness is a really interesting one and valuable. And just to follow up on one that Shelley mentioned, this idea that you see people at a slice of time. At this point, 83 years old, but there's a lifetime of strengths to draw on, and understanding that life story context can make a difference in terms of what you do in the future.
Absolutely, absolutely. Yeah, well, thank you all so much for weighing in. Yes, please.
Can I just build off something Tom said?
Absolutely.
I think we also, sometimes we lose sight of that our perceptions of health may be different than Geraldine's.
Yeah, that's a great point.
Understanding what her perceptions of health are and valuing them is key in interventions and readiness and all that.
Absolutely. Yeah, I really like that. Yeah, so we could continue to assess not only where she is now, but how she is defining sort of optimal wellness in each of those dimensions. And instead of just us kind of overlaying our own definitions of that, allow her to be able to help guide us. And that may dovetail with readiness to change. She's going to be more ready to move in the direction of what she wants than to be ready to move in the direction of what we want. And so I think that's a helpful paradigm shift to recall. All right.
You want us to keep going?
I'm happy to take one more, and then we can kind of move forward to the final phase of the talk.
Well, I want to go back to earlier. There was a question or a comment about the impact of ageism.
Okay.
And I know you talked about that earlier today with us.
Yeah.
And the impact that has not only on Geraldine, but on the people who might be caring for Geraldine and the ageism around caregivers as well.
Absolutely. Yeah. Yeah. There's there is a propensity for for us as a country to have ageist views around someone like Geraldine, and so we have to, like, as we're working with her and as we're working on these interprofessional treatment teams, there is some degree of just a working assumption that people represented on those teams may have certain attitudes about aging that they're bringing with them into those conversations. We ourselves have to continue to do that work. We could spend a whole bunch of other time just kind of really drilling down what are my implicit biases around aging, around other people as older adults, around myself as a future older adult, and how does that then kind of leak into the care that I'm providing. So being able to practice what I call developmental wellness, not only for her, for Geraldine, but also in ourselves is really vital. I do want to share with you, as we kind of close things out, just a couple of examples of applications using these different models. So I'm going to walk you through just 3 brief examples of this: a resilient aging pilot program, a wellness coaching pilot program, and embedding counseling services within a continuing care retirement community. So on the next slide, you'll see just a little bit about what we called the Reframing Resilience or Resilient Aging Group. This was a pilot of an 8-week program built around resilience. We used a 6 dimensions of wellness model to kind of guide the curriculum. This whole study preceded the 8 dimensions of wellness that I shared with you, which is why the numbers are a little bit different. But we had 29 older adult participants who were at an adult day health center, ages ranging 59 to 94. This was a pretty high acuity population of people. Many of them were Medicaid and Medicare, dual eligible, and so that tells you a little bit about socioeconomic status, about a lot of individuals with chronic health conditions and healthcare comorbidities that were represented there. And what we did was we had about half of that sample at a time, and we would have a conversation in a space that looked kind of like this, talking about what do you think resilience is? What's it all about? How does it show up in your life? How does it show up when we think about these different dimensions of well-being? And one story I'll share that was really interesting, I was leading the group, asking them to think about resilience and to think about a person in their lives, a person that came to mind when they heard that word, who really exemplified what resilience was. And this is after we had been talking about it for a few weeks. They were starting to kind of internalize some of our work around changing their own self-concepts. But I'll never forget, I asked the question, so who comes to mind as like the paragon of resilience? And a woman in her 70s, wheelchair-bound, we'll call her Pearl, raises her hand. And so, yeah, Pearl, what do you think? And I'm expecting Pearl to say, a family member or a celebrity or some other like larger-than-life presence. That's who I think of when I think of resilience. But Pearl didn't say that. Pearl looked at Mary, call you Mary, and said, you know what? Mary is who I think embodies resilience. Because every day we sit here and we watch Mary have to get up and go do physical therapy, which was embedded within this adult day health context. And I know that I know it's not easy on her. I know that it hurts sometimes, but she does it. She puts one foot in front of the other. And so when I think about resilience, I think of Mary. Okay, that wasn't what I was expecting, but I like where this is going. So then Mary, blushing, raises her hand and says, well, you know who I think about? I think about Joe. And points over to Joe. Says, Joe's been through a lot. You all know what Joe's been through. Like, I have no idea what Joe's been through, but but people are nodding, because they're part of a community, they're part of a context. Joe doesn't complain. He just continues to do what he needs to do to get through all the stuff that he's going through. Joe is who I think of when I think of resilience. And so before long, it's like contagious, this sort of notion of we're building community resilience right there. I have a brief quote from one of the participants to share with you on the next slide. It just says, I think my disabilities, we've lost an important part of our life that we lived prior to this disability, and to be able to operate now and feel good about ourselves means that we've been resilient and grown with the disability in order to do that. So again, just this notion that people are contextualizing resilience for themselves, for their neighbors, for people that they care about, was something that really stuck out to me. If you would skip ahead 2 slides, give you another little snippet. So this is a partnership with Wake Forest, Virginia Tech, and the Mather Institute. Mather Institute is a large nonprofit that owns and operates senior housing across the country. And we work together on a wellness coaching program, 9 weeks built around the 8 dimensions of wellness. What's really interesting about this is that the people providing the coaching are staff members within these retirement communities. So these are individuals who said, I want to become a wellness coach. And we put them through a training curriculum. They ended up putting in roughly 40 hours of training, which is a decent amount given all of the other responsibilities they have. And through that then, they were equipped to become coaches and to do sort of a hybrid of individual coaching and group coaching with residents living in the communities where they work. You can see on the screen here some of the results. So we asked people to identify how the coaching program impacted their wellness across these 8 different dimensions. You can see that relational and physical wellness were the most beneficial, but some other benefits in some of the vocational, developmental, emotional, cognitive, spiritual realms, contextual, something that lagged a little bit behind, but this wellness coaching pilot was really interesting. We ran about 80 people through it across the country in different communities, and we're actually setting up a new training cohort because there's been interest in continuing to expand this. And then on this next slide, I want to share with you one other kind of application. So at Virginia Tech, we have a partnership with a continuing care retirement community right here in Blacksburg where we're located. And every year we'll have 1 or 2 interns from our counseling program who will do their graduate internship within Warm Hearth Village. And so they end up functioning as an embedded, integrated mental health professional who can work with people across the sort of aging spectrum. So Warm Hearth Village has independent living residents who are interested in counseling for anything you could think of, the same things that most of us want counseling for. There's also folks in assisted living and in long-term care, and in those we have social workers who are helping make referrals to the counselor and helping get those sessions set up. So just another example of how we can take emotional well-being and access to mental health services, and instead of waiting for a person to come to the professional's office, we take the care to them, incorporate it into that setting. So those are some applications, and I do know that we have a little bit of time remaining for questions, for other reflections, not necessarily just about Geraldine's experience, but about anything from today's talk that you might want to just share, think about a little bit more. Yeah.
A couple of things. One is there's a lot of conversation about the importance of community. Given the concept of readiness in mind, there's a lot of emphasis to get folks connected with the community to address loneliness and isolation, even post-pandemic.
I think the importance of connection and community. There's a lot of ways you can go with that. One thing I'm thinking about with this partnership is, and this is just kind of a germ of an idea that hasn't fully been fleshed out yet. But we had the idea, what if we, during like new resident onboarding, as part of that onboarding process, so a person is moving into this retirement community, and they're getting a bunch of resources, and here's what we do, and here are all the cool things we have going on. What if during that onboarding process, they also got some information about this embedded counselor and some normalization around, mental health care is one of the things that we provide in this context. And the reason that your comment, Shelley, got me thinking about that was that transition into a new community can be something that is a struggle in and of itself, and being able to kind of transition from having the relationships and friends and family that I was previously affiliated with to now sort of being, dropped into this new neighborhood and expected to, make friends and get to know people. What if we had other ways to help onboard counseling as sort of a way to transition into that? You had a question too.
I have a question. So, as a social worker,
Yeah.
I'm really trying to keep the support I provide person-centered. How do I get
Yeah.
at what they feel they could benefit from working on the most, or their dimension of wellness?
Yeah.
Without imposing what I think.
Sure, yeah. So the nice thing about having that model is that you could introduce this as sort of the breadth of areas that we can help you with and help you think about. And you can then introduce maybe some broad parameters of like what those dimensions are referring to, but really allow the client or the consumer the opportunity to prioritize. Like, is this an area that you think is relevant to you right now? Maybe you attach like a 1 to 3, and 3 is, this is something I definitely want to talk more about, and maybe 1 is something that's like, maybe if we get to it in the future, but it's not pressing for me. And so allowing the person to prioritize which of those dimensions is most useful to them is one way I think that we can kind of honor their perspective and their voice while still having some degree of boundariedness to what we're trying to do together. And if there are things that are not well represented there, then we certainly want to have space for that too. And that could come in the form of just like, is there anything else that you can come up with or think about that doesn't seem to be reflected that you would like to rate as a 3 so that we can talk more about it? Because I think part of what we're trying to do then is help prioritize where our care resources should go so that the person can really kind of drive that process. And if you're in a situation where you're working with that person on a consistent basis or several different meetings, maybe after the first couple of meetings you do a little bit of a check-in, like, so we've spent some time focusing on these things. Does it feel like we're starting to get at what you were really hoping for in the first place, so that we're not sort of on a rabbit trail when that's not really the thing that they were hoping to work on? But yeah, I think there's a lot of ways to empower the client or the patient to kind of center like what their needs are and what their opinions are about what they need. And obviously it takes time to do that. So one challenge, if we were to challenge and critique, which we always should be doing, like things like this, there's a lot of stuff to cover, and maybe I have 8 minutes with the person or 20 minutes with the person. How are we possibly going to learn everything about Geraldine's life story? That is an inherent challenge, and so how can we think of ways to make this more concise, kind of get to the point, but allow it to still be something that represents the breadth of who Geraldine is?
So there's a great comment in here
Yeah.
about what a great opportunity to use motivational interviewing.
Yes,
you know,
yes.
to work with folks around their ambivalence and where they want to go.
Yeah.
And it really is much more person-centered than, as you say, going with what you think they need.
Yeah.
So it was a great comment. You and I talked just very
Yeah.
briefly about the intersection of
Yes.
resilience and vulnerability.
Yes.
And how you gauge that and how you have to be careful not to see one excluding the other.
Yeah.
Can you say a few words?
Yeah, that's a great point. So, big caveat with this sort of wellness resilience paradigm is that we don't use these to replace grief, loss, trauma, lament, struggle, like all of the things that a person may be dealing with, and they may not be ready to put that down and say, okay, how do I flourish? How do I thrive? How do I survive? How can I be resilient? So we have to, as the professional, hold those things in tension and help the people that we're working with understand that in some ways, trauma and resilience are sort of two sides of the same coin. Lament and flourishing, same thing. Like there is a way to, within the humanity of Geraldine and each of us, there's a way to talk about our struggle, talk about the things that are really painful, and the ways that we've survived that and tried to move one foot in front of the other. And so in terms of vulnerability, we're never asking the person to talk about resilience as a way to then never have to talk about pain and struggle again. That's not what we're trying to kind of guide them toward, but rather as a way to hold those things together at the same time and to be able to say that my resilience allows me to navigate pain and trauma and struggle. And in spite of my resilience, I may still experience some of those things. So holding those things together.
So I really hate to come up here to end this time. Thank you so much.
My pleasure.
Let's all.
Thank you.
And thank you to Tom User and to Kelly Fox and to my staff here at CC and CCSME. Peggy, thank you so much. We thank everybody.
Thank you.
She's still here. That's great. So, thank you. And we just want to tell you about the upcoming events. We've had an amazing first two events. Thank you for being here this season. And the next one, September 28th, is a little different. It's our collaboration with the Planetary Health folks, and it's called Grow with the Flow, and you will love this.
Yeah.
Resilience and adaptation in a changing world. And this is their little tagline. We are living in strange times. Radical changes are reshaping our world, society, and lived experience. Our resilience and adaptation are more important than ever. Join us to explore these. So you have come next time by Zoom or in one of our rooms next Wednesday. Thank you all for being here, and thank you so much.
Thank you.
All right.